very much. Apology. All right, so welcome everyone to the GECO Fellows meeting. Just to inform you that GECO is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. This program runs every second week on Mondays. And yeah, if you've got any questions during the presentation, you can pop them in the chat, or you can ask at the end of the talk. So I am one of the HOUs in gastroenterology. I'll be facilitating this presentation by Dr. Mustafa Hkouma. Mustafa, you just correct me with the pronunciation of your surname. So he's going to give two talks, one on Barrett's esophagus and the other on eosinophilic esophagitis. So I think after the first talk, we'll allow questions. And then after the second talk, we'll allow questions based on that talk. So my function is to facilitate. So what I'd like to do is to ask all the junior fellows or fellows who are not writing this current exams to come up with questions, lots of questions for Mustafa, and then he can answer. If he can't answer, then the other fellows who are also writing the exams can then answer the questions. We'd like to make it as interactive as possible. Over to you, Mustafa.
Thanks, Dr. Nia. Good evening, everybody. Dr. Mustafa Ben Hkouma. I'm one of the fellows on behalf of Derby KwaZulu-Natal in Kosi Albert Latuli. My first talk is about Barrett esophagus. So the definition, it's a portion of the normal distal squamous epithelia lining has been replaced by metaplastic columnar epithelium, but must be clearly visible endoscopically, 1 centimeter above the OG junction, must be confirmed histologically as well. The Bragg, which is circumferential and maximum length of extent criteria, is used for endoscopic reporting. Is an example for Bragg criteria. So that's the origin, the level where the OG junction, or the circumferentials, the area of the circumferential, and the maximum length or maximum extent of metaplasia. As you see there, it's a C2 and M5 in this example. These are classical pictures of Barrett esophagus patient. I cannot talk about the tongue or the extent, it's not clear. The other one, it's more clear. It's another picture of Barrett esophagus, the circumflex and the maximum length. Calculate from OG junction extended up. So what's risk factor of Barrett esophagus? Previously was classified to alternative and unalternative risk factor. Currently, just risk factor in general, it's gender, which is male specifically, old age, more than 50 years, patient with chronic gastroesophageal reflux disease, Caucasian population, central obesity, defined as waist circumference more than 102 centimeter, or waist hip ratio more than 0.9. Smoking, and family history of Barrett esophagus or esophageal adenocarcinoma. Diagnosis, how we diagnose. So, as I mentioned earlier, the location of diaphragmatic hiatus or OG junction and squamocolumnar junction should be reported in endoscopic report. In patient with suspect Barrett esophagus, at least 8 random biopsy should be obtained to maximum the yield of intestinal metaplasia on histology. In few cases, if the patient with a short 1 or 2 centimeter segment of suspect Barrett esophagus and 8 biopsy are unattainable. At least 4 biopsy per centimeter circumferential Barrett esophagus and 1 biopsy per centimeter in tongue of Barrett esophagus should be taken. This is the histological features or histological manifestations of Barrett esophagus. We look for the right slide. This is how the esophagus looks like. Stratified squamous, the columnar, simple columnar cell, and the stomach and transition in between. For the left one, just focus in the long arrow there. That's where the glandular epithelium with all columnar cell punctuated by round to oval goblet cells. And this is where is the columnar metaplasia start. And in the lower, or the short arrow, this is just area of infection. In this case, this example for patient with chronic gastroesophageal reflux disease with Barrett esophagus. Screening. It's not recommended, but can be considered in several cases. For example, patient with gastroesophageal reflux disease with multiple risk factors. Some high-risk patients, as we mentioned earlier, male, Caucasian, smoking, positive family history of Barrett esophagus. The life expectancy of the patient should be considered before screening. In esophagitis, with Los Angeles classification BCD, repeat endoscopic assessment after proton pump inhibitor therapy for 2 to 3 months is recommended. If initial endoscopic evaluation is negative for Barrett esophagus, repeating it's not recommended. Surveillance. Counseling regarding risk and benefit of surveillance before you start. Endoscopic monitoring with histological assessment is the only method of surveillance. Although there is some controversy between British guideline and American guideline regarding the B53, we'll talk about it later on. Dysplasia confirmed by 2 GI pathologists is currently the best issue biomarker for assessment of cancer risk. And as the American College of Gastroenterology Society guideline define the senior pathologist, those pathologists seen more than 100 Barrett esophagus patients endoscopically. Oh, sorry, histologically. High resolution endoscopy or high definition endoscopy should be used in Barrett esophagus surveillance. Chromoendoscopy, virtual chromoendoscopy are not superior to standard white light endoscopy in Barrett esophagus surveillance and are therefore, they're not recommended. CT protocol, which should be employed for 4-quadrant biopsy at 2 centimeter interval in patients without dysplasia and 1 centimeter interval in patient with prior dysplasia. To simplify the surveillance, so Barrett esophagus make it easier. You look for the length, and if there's a dysplasia or there's no dysplasia. So divided first one Barrett esophagus with less than centimeter without dysplasia. So repeat endoscopy with quadrant biopsy to confirm the diagnosis. If repeat endoscopy confirm absence of intestinal metaplasia or dysplasia, discharge from surveillance is encouraged. So this one less than 3 centimeter without. The other one, Barrett esophagus, less than 3 centimeter with intestinal metaplasia. Endoscopic surveillance every 3 to 5 years. Patient with Barrett esophagus 3 centimeter or longer, surveillance every 2 to 3 years. So yeah, with a quadrant esophageal biopsy every 2 centimeter, just to summarize what we've been talking about. If it's squamous epithelial query sample error, review endoscopic finding, consider repeat endoscopy. If it shows glandular metaplasia and confirmed Barrett esophagus, clinical review of patient fitness and preference, then divided according to the size, to the length, the maximum length is less than 3 centimeters with gastric metaplasia, no intestinal metaplasia or columnar metaplasia. Repeat endoscopy. So the repeating one is less than 3 centimeters with gastric metaplasia considering discharge. If the repeating one or patients got less than 3 centimeters and confirmed intestinal metaplasia or dysplasia, repeat endoscopy every 3 to 5 years. For those one maximum length 3 centimeters or more, repeat endoscopy every 2 to 3 years. Now, surveillance for those dysplasia patients. So after two independent pathologists confirmed, GI independent pathologists, see if indefinite for dysplasia, you continue patient PPI and you repeat scope in 6 months with maximum acid suppression, PPI. No definite dysplasia, you follow non-dysplasia chart we've been talking about. If definite dysplasia confirmed, follow the low grade or high grade accordingly. So the low grade dysplasia, endoscopic every 6 months until the 2 consequence evidence of non-displaced Barrett esophagus. If there no definitive dysplasia, then follow non-dysplastic. In high grade dysplasia, multidisciplinary team discussion should be occur and therapeutic interventions will be discussed. Management of Barrett esophagus. Chemopreventive or chemoprevention. Once daily PPI therapy recommended. Routine use of twice daily dosing is not recommended. Aspirin shows some effect, but aspirin or NSAID should not be routinely prescribed as an anti-neoplastic strategy. Endoscopic therapy. To simplify, just classify to 2 types. There's flat or non-nodular type and the nodular type. The non-nodular type or flat, the radiofrequency ablation is currently the preferred endoscopic ablation therapy. For the nodular one, it should go under endoscopic mucosal resection as initial diagnostic and therapeutic option, then followed by radiofrequency ablation. So in patient had EMR, which is endoscopic mucosal resection specimen with high-grade dysplasia. Endoscopic ablation of remaining Barrett esophagus should be performed. And a patient with AMR samples with neoplasia at deep margin. So the residual neoplasia should be assumed. Surgical, systemic, or additional endoscopic therapy should be considered with multidisciplinary team discussions. So what is the stage of esophageal adenocarcinoma? Just to simplify the management in the next slides we're gonna go through. So it's a TNM class staging. The T staging here, TX, its primary tumor cannot be assessed. T0, no evidence of primary tumor. T in situ, high dysplasia, high grade dysplasia. Now we are just more focusing on T1 and T2. So T1 divided to T1A to T1B. So T1, it's affect lamina propria and muscularis mucosa or submucosa. So if it's affect only mucosa, it's 1A. If it's affect submucosa as well, it's 1B. Then submucosa are divided to superficial or deep to SM1, SM2, SM3. T2, tumor invade muscularis propria. T3 invade the adventitia, deeper, and T4, which is tumor invade adjacent structures. Endoscopic therapy. Endoscopic ablation therapy is not routinely applied in non-dysplastic Barrett esophagus. Barrett esophagus with low-grade or high-grade dysplasia, endoscopic eradication therapy is the procedure of choice. In patient with T1A, which is affected mucosa, esophageal adenocarcinoma, endoscopic therapy is still the preferred therapeutic approach. Another important in T1B, multidisciplinary surgical oncology team should be occur before embarking on the endoscopic therapy. EUS may have a role in assessing and sampling regional lymph node, but not in treatment. Endoscopic therapy may be an alternative strategy to esophagectomy, where in specific case in superficial, there's 1P SM1, which is superficial in the submucosal layer, or well-differentiated neoplasm, lacking lymphovascular invasion, or both surgical candidate. Is an example for patient with high-grade dysplasia treated with radiofrequency ablation. If you look from the top on the left side, APC, there was a patient with treated with radiofrequency ablation, and from D to DEF to F, this patient after up to 6 weeks from the radiofrequency ablation review, you found in number E, there's a nodule there. Was treated with submucosa or with endoscopic mucosa resection and followed by radiofrequency ablation. The last three, G, H, I, the last one I was reviewed 3 months after radiofrequency ablation, which is clear there's much improvement. Another example for radiofrequency ablation, the way the procedure how it's done, and the last slide show 3 months. Follow up, show scarring for the radiofrequency ablations. Number F. Surgical therapy. The indications in esophageal adenocarcinoma with invasion into submucosa, like we mentioned, SM, the one submucosa T1B, SM2 and 3. The other in between surgical or multimodality therapy, those patients, like we mentioned earlier, T1A or T1B, SM1 can be treated endoscopically. Fully differentiation, surgical or multimodality therapy, it's according to MDT meeting or MDT discussion. Lymphovascular invasions, incomplete endoscopic mucosa restrictions. Just to summarize what we've been talking about, the 4-quadrant biopsy CT protocol, presence of dysplasia confirmed by 2 GI pathologists. If there is no dysplasia, surveillance continue according to the maximum length, less than 3 centimeters without internal metaplasia. Continue PBI, repeat scope after 6 months. Oh no, sorry, so patient repeats its scope after 6 months, there's nothing, so the patient discharged. If less than 3 centimeters with instant metaplasia, scope every 3 to 5 years. If the maximum length 3 centimeters or more, repeat scope every 2 to 3 years. In indefinite for dysplasia, optimized BBI therapy, repeat scope 6 months. If there's dysplasia, treat as a low grade or high grade dysplasia. Low grade, repeat scope in 6 months. Confirm with 2 pathologists. Discuss an MDT meeting. Offer radiofrequency ablation. If radiofrequency ablation not performed, so 6-month endoscopic surveillance is recommended. In a high grade or patient with esophageal adenocarcinoma T1A, MDT discussion, radiofrequency ablation with 3-month follow-up first year, then yearly thereafter. Is the nodular one. Start with AMR, Endoscopic mucosa resection of the nodular mucosa. Dysplasia confirmed by 2 GI pathologists. Now divided to low grade, high grade, or esophageal adenocarcinoma. Low grade, MDT discussion of radiofrequency ablation after AMR, 6-month endoscopic surveillance. High grade, discuss MDT, radiofrequency ablation to ablate residual Barrett mucosa. T1A with SM1, MDT discussion, radiofrequency ablation or endoscopic ablation for the residual mucosal or residual Barrett mucosa. The T1P discussion with MDT, if it's M1, it's SM1 involve the upper third of the submucosa. Oesophagectomy can be performed. For both surgical candidate ablation can be considered. Also will differentiate and no lymphovascular invasion. For those one with SM2, that's one involving the middle to lower third of the submucosa, oesophagectomy recommended. Management of Barrett oesophagus after endoscopic therapy. Endoscopic surveillance should be continued after successful endoscopic therapy and complete elimination of intestinal metaplasia. Complete elimination of intestinal metaplasia with high-grade dysplasia before the ablation. Continue endoscopic surveillance every 3 months for the first year, then every 6 months for the second year, then annually thereafter. This is in high grade. In low grade, with complete elimination of intestinal metaplasia, endoscopic surveillance every 6 months in the first year, then annually after that. Just quick review. This is differentiation between all guidelines, British guideline, American guideline, and international consensus for Barrett oesophagus. In a table, just to summarize the difference between or what would be in the same. So the definition, I think the difference between the British Society guideline and American. In a British, same visible metablastic columnar epithelium more or equal 1 centimeter above the OG junction, plus biopsy confirmation of columnar metaplasia. In American guideline, visible metablastic columnar epithelium 1 or more than centimeter above the OG junction, plus biopsy confirmed of intestinal metaplasia. From the endoscopic landmark, the same. It's the proximal extent of gastric fold. They're using Prague criteria for 3 of them. Biopsy protocol, almost the same, just the difference for the 8 random biopsies. There's 4 quadrant for SETA protocol. Z-line routinely biopsy is not recommended. Confirmation of dysplasia. The difference here, the difference in British guideline, they've been using of P54 as a biomarker to aid dysplasia diagnosis, but in American it's not recommended. Non-dysplasia, the one I've been talking about was British guideline, American for all size less than 3 or more than 3 centimeters, all the surveillance 3 to 5 years. The rest the same both sides. Indefinite dysplasia, low grade or high grade, or esophageal adenocarcinoma. Take home message: Barrett esophagus is diagnosed through an upper GI endoscopy and biopsy, so endoscopic and histological. Chromoendoscopy, virtual chromoendoscopy are not superior to standard white light endoscopy in surveillance. Nodular Barrett esophagus treated with AMR followed by radiofrequency ablation. In flat Barrett esophagus, radiofrequency ablation is the preferred endoscopic therapy. Endoscopic surveillance should be continued after successful endoscopic therapy and complete elimination of intestinal metaplasia. Thank you.
Thank you, Mustafa. I can't see any questions in the chat. I don't know if anybody has questions for Mustafa. Okay, if not, can I just ask you, so on your slide under surveillance, you said, before you start surveillance, you will tell the patients about the risks and benefits of surveillance. So if I'm your patient, can you tell me what sort of risks and benefits you would warn me about or you tell me about if we were to proceed with my surveillance? Okay.
So let's go for the benefit. The benefit, if there's a Barrett esophagus with low-grade or high-grade dysplasia, or the patient was treated earlier and avoid progression of disease to esophageal adenocarcinoma, improve the outcome, improve the future life. But from the disadvantage, or depends on the patient life expectancy. So if patient, let's say patients have to explain the risk when you do radiofrequency ablation or endoscopic mucosa resection, the risk of perforation is there, the risk of bleeding is there, the risk of procedure or anesthesia or local anesthesia before procedure is there. So counseling patient is informed consent according to patient procedures and the complication of procedure thereafter.
And informed consent is very important amongst us as clinicians. Before we subject any patient to any endoscopic therapy, we ourselves should know the risks associated with the endoscopic procedure. So if I were to decide, I know that you said endoscopy is not recommended, but if I were to decide that I want to go ahead and do endoscopy for this columnar lined distal esophagus, what sort of endoscopy would you recommend I go for?
Can be virtual endoscopy.
If it's virtual, which one? And if it's dye, which one?
I'm not sure specifically which one.
The other fellows who are writing exams? Let me see who's here.
From a virtual endoscopy point of view, virtual endoscopy, I think the modalities are a narrowband imaging, I think, on Olympus and iScan. And then from a dye-based endoscopy, gosh, it's just left me for a second now.
You can get it from your kitchen cupboard.
Oh, acetic acid. Acetic acid would be one we could use.
Okay. You have a question, Zamo? Do you want to just ask it?
Yes, I just wanted to ask. Thank you, Mustafa. From if you've got endoscopically visible columnar epithelium, and then you proceed to biopsy the patient, I think you showed there that if you've got gastric intestinal metaplasia, then you're not going to follow that patient up. Obviously, if the extent is less than 3 centimeters. But how do you tell the difference between gastric metaplasia and intestinal metaplasia?
I think it's going to be histological by the pathologist if there's a large number of goblet cells in the metaplasia itself, or in the intestinal or the columnar layer. It's columnar epithelium surrounded by the goblet cell is keeping with intestinal metaplasia or columnar metaplasia, although it cannot be differentiated. It looks like identical, but it's not identical in nature.
If there are no other questions, I'd just like to ask another question. Do any of the fellows work in centers where therapy for Barrett's esophagus is performed, specifically RFA or EMR?
No.
Okay, so what it entails, especially with the RFA, you can use, so let's say, for instance, you're dealing with circumferential Barretts. So there you can use the balloon. It used to be called the Halo 360. Basically, it's a balloon that you inflate at the bottom end of the esophagus, and it's got some electrodes along its circumference, and then it's attached to I can say a power generator. So previously you'd have to do a sizing balloon. So you would size the circumference of the esophagus to decide on the type, on the size of balloon you were going to use. But now the current balloons that are available do not require sizing. So you identify your Barrett segment and then you push your balloon to the segment. It almost looks the same as an achalasia balloon, except it's not as long and it's got electrodes around its circumference. So once you've inflated it, then you burn the area and then ends up looking white. And then you can scrape off the white residue and then do another burn. And then that will be that session. So, but you can burn along the length of the esophagus, all right? But if you've got a tongue, then you can use a dedicated catheter. It looks like a nail. So it goes in through the scope, and then you can just burn along that tongue of Barrett's. After burning, you scrape off, you burn again, you scrape off, and then after that, when the patient goes home, you give them instructions on the continuation of acid-lowering medication, and also maybe they would have to be like on a liquid diet for a certain number of hours, and then a soft diet. And then with EMR, there are companies that do EMRs usually for these nodules. They use this CAP-assisted technique, so it's the same type of system. It looks like the system that you'd use for esophageal varices, because you'd identify the nodule, you can mark the perimeter of the nodule with the tip of a snare, and then you suck the nodule into the cap, then you fire the rubber band, and then you cut. Usually the esophagus bleeds quite a bit, so you must be ready with your hemostatic mechanism. So if you're going to use clips or APC or whatever means you use to do the burns. But because of RFA, there's also that risk of the buried Barretts. So it's not very common that it happens, but that's one of the reasons why you keep the patients under surveillance. So I think, yeah, maybe amongst us, yeah, so Tanya, why don't you say anything? Yes, so definitely, especially after the 360, because you burn the circumference of the esophagus, then there is a risk of stricturing. So one of the things that you tell them then when you tell them about risk and benefits of surveillance is about the complications of RFA stricturing being one of them. Is there anybody else who'd like to add anything? Prof. Sitsedi, I'm not sure if any of the centers have got access to these things. Maybe we can arrange for the fellows to visit that center. Prof. Hkouma said that they've got everything, so maybe we can check with them, just so that the fellows can get exposed to.
Victor does sometimes bring the RFA catheter. He has once or twice, but we haven't had him here in a long, long time. But yeah, the thing that you say, the nail-like of catheter, we've used it before on 1 or 2 patients. It works well. The precision of applying the heat to the tongue of the Barretts works quite well. But we don't have it. We have to source it from Victor when we have a patient who needs it.
Yeah.
But we don't do screening, and actually, we probably don't do surveillance, honestly. I think we've got very few patients.
Yeah, same here. Yeah. Okay, very well then. Thank you, Mustafa. So I think in the interest of time, let's move on to the next talk, which is eosinophilic esophagitis.
Okay. Second topic is eosinophilic esophagitis. Definitions. It's a chronic immune antigen-mediated esophageal disease characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation with the following criteria. So symptom related, maximum eosinophil count more than 15 eosinophil per high power field, eosinophilia limited to the esophagus, and excludes the other possible causes of esophageal eosinophilia. Epidemiology, it's more common in men, common in a white population, common in children, but can be present in the third and fourth decades as well. Pathogenesis. So it's divided by two classifications. It's environmental, genetic. So environmental, in a bird, childhood factor, seasonality, H. pylori, genetic, or it goes food with aeroallergen. So the important start here with the dendritic cells, looking as antigen presenting cell in a body, it's like a foreigner. It stimulates T helper 2, which from there stimulate interleukins, specifically interleukin 5, interleukin 4, interleukin 13. So one by one, interleukin 13 causing fibroblast. Interleukin 13 can decrease the desmoglein, filaggrin, and calopin 14. Interleukin 4 stimulate eutaxin 3, which is increasing. Interleukin 5 increase the eosinophil. Eosinophil stimulate interleukin 9. And from the combined outside TSLA, which is thymic stromal lymphopoietin, basocells and eosinophil, stimulate mast cell, tumor growth factor beta, increase periosteum, and increase fibrosis. So in brief, after stimulate the T helper 2, the chemotactic started from there with multiple interleukins, 5. Each one is important in the management of the future. We're going to talk about it later on. So interleukin 13 stimulate eutaxin 3, interleukin 5 straight to eosinophil, interleukin 13 fibroblasts, and increase the calbin, decrease the filaggrin and desmoglobin. Interleukin 9 stimulate mast cell to increase the periosteum and inner by fibrosis. So diagnosis, at least 5 biopsies must be obtained, preferably from both the proximal and distal esophagus. Why? Just to account for the heterogeneous nature of the tissue eosinophilia. To diagnose the eosinophilic esophagitis should include symptoms, endoscopic features, and histological features. Start with the clinical symptoms. Dysphagia, food impaction, nausea and vomiting, can present with heart pain, abdominal pain, chest pain, also can present with dry rhinitis, asthma, and atopic dermatitis. Endoscopic features, dimension vascular pattern, mucosal furrows, trachealization, thick mucosa, exudate, structure of narrow calibers, and rings. Classical for one, number A there, top in the left, is a normal caliber esophagus with a normal aberrant mucosa. On number B, if you look, there's a few white exudate. C, trachealizations. D, longitudinal linear furrows. E, cotton wall or cotton-like exudate, mimicking like candida, but biopsy finding multiple eosinophilic containing microabscess. And the last one, F, it's ringed esophagus. Histological changes or histological features. Thick epithelium with eosinophilia, abnormally long papilla, fibrotic lamina propria, microabscess, extracellular eosinophilic granules, increased extracellular major basic protein. The pink dots there, that's an eosinophil. With increase the number of the single eosinophil, with immune cell, non-normal present in a large number, and it looks like pink color. The single epithelial cell, the one in a circle in the purple, and that's inside the esophagus, the lumen. Just focus in a pink color eosinophil shades. The diagnostic challenges. So there's terms called proton pump inhibitor responsive esophageal eosinophilia and gastroesophageal reflux disease. It looks like esophageal symptoms and histological findings same like esophageal eosinophilia, but symptom or symptomatic and histological response to proton pump inhibitor. So how to exclude? This is PPI response esophageal eosinophilia, or this is eosinophilic esophagitis. So to exclude it, 2 months course of PPI followed by endoscopy and biopsy again. If the features improving histological response, it's giving with PPI response esophageal eosinophilia. If it's not, giving with eosinophilic esophagitis. Clinical endoscopic and or histological response to PPI does not establish gastroesophageal reflux disease as the cause of esophageal eosinophilia. So further investigation, further evaluation for GERD should be recommended. pH monitoring or pH study should be done. Treatment. So it's divided to pharmacological therapy, dietary therapy, endoscopic therapy. Start with pharmacological therapy. Topical steroid, it's a mainstay of eosinophilic esophagitis treatment and a first-line agent. Examples, fluticasone and budesonide. They improve patient symptoms, decrease esophageal eosinophilia, generally well tolerated. Systemic steroid, such as corticosteroid, is a second line of treatment. It is effective, but limited usage due to side effect and recurrence after withdrawal. Used where topical steroids are not effective. Leukotriene antagonist and mast cell stabilizer. In American College of Association of Gastroenterology guideline, they mentioned in the Montelukast, there been a study was done compared between patient in Montelukast and placebo. There is no improvement, so it was not routinely recommended. Also, mast cell stabilizer, example, chromoline sodium, also is not routinely recommended. Immunomodulator, such as azathioprine or 6-mercaptopurine, excellent response to esophageal eosinophilia. The problem relapse after the treatment discontinued, so it's not recommended to treat eosinophilic esophagitis. Biologic. The biologic treatment came out from pathogenesis. If you remember, when we talk about interleukin 5, interleukin 13, interleukin 4, and eotaxin, all those one going to come from there. So it's anti-interleukin 5, mebilizumab, risiluzumab, improve symptom, reducing level of esophageal eosinophilia, but not yet commercially available, not recommended for routine use in esophageal eosinophilia. Omalizumab, antibody to IgE from mast cells, not effective in eosinophilic esophagitis, not recommended for use in eosinophilic esophagitis. And anti-interleukin 13 and eotaxin 3 are under development. Chemoattracting receptor homologous molecule expressed on the T helper 2 cells, antagonist, has mild improvement in esophageal eosinophilia, further study will be needed to assess in clinical utility. This example for the pathogenesis and the part where the medication or the biologic starting. They've been trying to use TNF infliximab. It was also not recommended. With an eosinophil, muscle interleukin 5, interleukin 13, interleukin 5, interleukin 13 again, interleukin 4, and IgE antibody. Dietary therapy. There are 3 general strategies for dietary elimination in eosinophilic esophagitis. Number, either elemental diet or 6-food elimination diet or target elimination diet. Dietary therapy, the specific approach depends on local allergy and nutritional expertise and support, patient and family preferences, resources and motivation. If a patient decides to embark on dietary therapy, refer to allergist, may be considered to determine whether specific test for food allergies is needed. Start with elemental diet, can be difficult. The formulas are expensive, unpalatable, may need to be administered by enteral feeding tube, extremely restrictive, can adversely impact quality of life. The commonly used 6-food elimination diet, which is milk, egg, wheat, soy, seafood, and nut. More palatable than the elemental diet. After a food reintroduction protocol, for the many different studies showed wheat and milk were the most identified allergens. Target elimination diet. So food allergen identified and allergy testing are eliminated using skin prick and atopy patch testing. The response rate have been closer to about 55 to 75%, ranging in children and potentially lower in adults. Endoscopic therapy. Indication. The first consensus guideline for eosinophilic esophagitis recommended very cautious approach to dilation only after institution medical and dietary therapy. Esophageal stricture or narrow caliber oesophagus, another indication or symptom of dysphagia. Why guide bougie dilation or through the scope balloon dilatation are commonly used in practice. Complication, it's divided to 2, complication of eosinophilic esophagitis or complication of the therapeutic intervention itself. So the complication of eosinophilic esophagitis, it's acute food impactions, long and short segment narrowing, stenosis. Complication of therapeutic intervention, mucosal rent or tears, perforation, bleeding, infection due to chronic use of steroid, and nutritional deficiencies. Take-home message, diagnosis should include symptoms, endoscopic and histological features of eosinophilic esophagitis. Biopsy should be obtained from both proximal and distal esophagus. Topical steroid is the first-line treatment. Dietary elimination can be considered as initial therapy in treatment of eosinophilic esophagitis. Endoscopic dilatation considered with very cautious in eosinophilic esophagitis with stricture, not respond to medical therapy. Thank you.
Thank you, Mustafa. So I see there are no questions, but Thanks from Innocent. So I'm going to start with questions while Innocent thinks of questions to ask. So firstly, what exactly leads to food bolus obstruction or food impaction in patients with EOE?
Can I say again?
Why do they get dysphagia? Why do they have food bolus impairment, impaction? What sort of mechanisms are involved in that?
It's related to the antigen presenting cells. So it's aeroallergen. So it's inflammatory process. It happened in the esophagus, specifically would increase the eosinophil. So that cause decrease or with a complication or trichelization, whatever the features there, it's causing stuck the food in the esophagus due to narrowing there. One of those type, the narrow caliber esophagus, it stuck the food and caused food impactions there. That's what I know.
Would the other fellows like to add on possible mechanisms for leading to food impaction?
Is it not due to the chronic inflammation and fibrostenosis subsequently?
Yes, so fibrosis and stenosis, okay, which is mediated by the transforming growth factor that you mentioned in your pathway, Mustafa. It leads to fibrosis, and then that's how you get the dysmotility. But also the eosinophilia apparently also leads to increased stickiness of the esophagus. So that's why the food impaction is seen with solids and not, they don't have dysphagia to liquids. So they may not necessarily have stenosis, but apparently the hypereosinophilia leads to increased stickiness of the esophageal mucosa. So let's go to the questions. Is there a role for PPIs in the management of EOE?
Yeah, we just mentioned now, that's use patient with a proton pump inhibitor response to esophageal eosinophilia. So there is a role. It's controversial. So treating patient, you treat the patient for 2 months. Patient responding is going to be under classification of proton pump inhibitor response to esophageal eosinophilia. And but the treatment, if it's confirmed eosinophilic esophagitis, the treatment of choice is topical steroid.
So yes, Barbara, I think there was one study that showed that about 75% of patients with EOE will respond to PPI, and that's why the presence of food is also, it poses a diagnostic challenge, because the patients, a lot of the patients will respond to PPI, and that's why you have to take those biopsies proximally and distally to try and figure out what you're dealing with. What advice will you give to a patient you prescribe local steroid in terms of administration? How should they take the fluticasone and the budesonide?
Okay, there's previously was inhaler, but now they show it's showing tablet swallowed. It's more efficacious than using inhaler for topical steroid or injection of the esophagus. So I think the last study I went through, they've been using the oral swallowed. It was more effective than using any inhaler or intraesophageal injections.
Which oral forms? Is it the oral dispersible one, the viscous, the slurry? Do you remember which? So let's hear what Mzamo has to say about this.
I do believe, I think from a practical point of view, when you prescribe, you can prescribe your standard inhalers that you use for asthma, COPD, your fluticasone or your budesonide, if I remember correctly, except you don't prescribe it with inhaler, and then you tell them then to spray into their mouth and then to swallow that. But I do believe there are other ways to deliver the steroid, the slurry. And then you can also compound the steroid to, at a compounding pharmacy with certain compounds to make it more viscous and that it can coat the esophagus. So I think those are also ways of delivering the steroid.
Yes. Any of the other fellows who are writing, if they'd like to add on anything?
I think now from what I read, the viscous slurry is supposed to be the best tolerated and most efficacious.
Yes. All right, so because the oral, Mustafa, I'm just trying to think about fluticasone, for instance. I mean, I know they're doing these oral dispersible ones, but I think the ones that are more now being used are these thick viscous ones that line the esophagus and won't get flushed away too easily. I think the inhaler one, Zamo, especially with fluticasone, it was difficult to determine which dose would be more effective, whether the 440 microgram or 880, and then when they inhale them, one really never knows how much goes in, it gets swallowed. And sometimes when we swallow, some things escape through the nostrils. So it's difficult to know exactly how much is being delivered to the esophagus. But it is what we use because we don't have access to slurries and the viscous formulations. Is there a risk of esophageal adenocarcinoma in EOE?
I think I went through this. It's very few. It's about less than 1%. I think so. It's very few. It is.
If there is a risk, how do you think that risk arises?
It's a fibrosis, fibrous genetic. It's not a chronic inflammation. Chemotype could be genetics. I'm not sure exactly the mechanism, but it could be from the genetic, from fibrosis, stenosis, chronic inflammations.
Okay, I mean with the fibrosis, remember patients with EOE are also prone to GERD because of the dysmotility. So then the clearance of acid is impaired, and then they get prone to Barrett's, and then eventually adenocarcinoma. Is response to therapy based on symptoms, or is follow-up endoscopy with biopsy required?
I think both. Symptom first, then endoscopic therapy with removing the eosinophils, the high buffet.
But from what you've read, do they say that we should go ahead and
symptom?
So, because this would bring us to like whether we should have, in Crohn's we have treat to targets. So in EOE, should we have therapeutic endpoints that we're aiming for to see if our patients have responded?
No, sorry. I think there are some scoring systems specifically for EOE that can be used.
Such as?
Oh, I don't know what the name is, what the names are.
Mzamo, is that your hint?
Yeah,
yes.
that's me, yes. Tanya, I think it's the endoscopic reference standard or EREF score.
Yes.
That can be used. So symptoms, you can use an endoscopic score as well. And then the EREF stands for exudates, rings, edema, fibrosis and such. And so you can, based on all of those kind of endoscopic signs, they can actually be a score. So you can have an objective then measure of improvement endoscopically, at least, on top of the symptom improvement. And then obviously you can then also look at your so-called mucosal healing by looking at the eosinophils normalizing or getting becoming less than 5, I think is one of the targets that was looked at.
Mashiko was going to ask the same question. Yeah, because then we need to know if we can change the natural course of EOE. You know, if you want to avoid these patients from developing esophageal fibrosis and even stricturing, are we going to leave it at steroids? How strong is this? How strong is the literature against the use of immune suppressive therapies? Because generally the steroids are given for about maybe 8 weeks, because most people tend to be on short course of corticosteroids, and then you reassess. And then going forward, what then? Are we going to keep them on steroids? Are we going to then change them over to steroid-sparing drugs?
If you go practically continue the steroid for 8 weeks, then you start immunomodulate like azathioprine, but you have to counsel the patient, make sure patient if you the risk of relapsing if you could discontinue, and that's the way how to treat. But according to American College Association of guidelines, said immunomodulate is not recommended to use in eosinophilic esophagitis. Practically we're using.
So if symptoms recur, steroids.
Sorry?
So if symptoms recur after you discontinue steroids.
There's no other option now. Immunomodulate is there.
So Prof. Sisedi says the data is scant, but some studies suggest repeat biopsies after elimination diets to assess response. So this is if you decide to take the dietary route. Okay. Dr. Naidu says it's not entirely, I don't know if he is not or it is not entirely clear if there is any clear evidence that EOE poses an increased risk for esophageal cancer. Anyways, we rarely encounter it, but important to be aware of it. Okay. So I think we were supposed to finish at 7. Can I just ask maybe the last question on diet? So would you refer them to the dietitian, or would you start the 6-food elimination diet yourself? And if you were to start it yourself, would you go all the 6 groups, or would you go 2-4-6? 2-4-6 seems to be the buzzword in EOE food elimination.
Amen. If I would like to start, I start 2-4-6, but I prefer to transfer to the dietitian.
Of course.
Safer, more safer. An allergist, actually, what to do have it, yeah?
Okay. Yes. Definitely, we would refer to a dietitian, but apparently you can start with 2. And milk is, as you said, is said to be one of the culprits, the commonest culprits. So maybe you could start with the 2 least common, and then you gradually, actually you start with the 2 most common, and then you gradually eliminate the other 6. But yes, we would also just refer to a dietitian to do a more structured food elimination program. I don't think there are any more questions in the chat. Does anybody have any other questions? Okay, if not, then I'd like to just thank, do I call you Ben or Mustafa? For sharing these talks. It took a lot of time, but you did well in bringing us up to date with the current management guidelines. Thanks to the ECHO UNM and the ECHO India team for the support. There is a feedback form that's available in the chat, so if you can please complete that form. And recordings will be available on the Gastro Foundation website. Yes, again, thanks to the Gastro Foundation and the presenters. We will meet again on the 14th of March, where Dr. Tanya Khan will be discussing esophageal malignancies. Yeah, thank you so much.
Thank you, Dr. Nia. Thank you, everybody.
Thanks.
Thanks.